Good afternoon, everyone. On behalf of Dentium, I warmly welcome you all in today's webinar on bringing implants to life, a prosthetic phase. This webinar will be informative and beneficial for those who are planning to start their implant practices. And we are privileged to have Dr. Avantika Tripathi, MDS Oral and Maxillofacial Surgeon and Dentium KOL, as our esteemed speaker, bringing expert technical knowledge and practical insights on the use of dentium superline implants in the dental practice. We encourage all the participants to kindly stay until the end of the session to unveil the webinar special packages and get a chance to win superline fixture in the lucky draw contest. And thank you for joining us. Now over to Dr. Avantika Tripathi.
Thank you, Mr. Suburu, for the kind introduction. A very good afternoon to all of you. Welcome to today's webinar on bringing implants to life, the prosthetic phase. So when we think about implant dentistry, we usually focus on surgery. But in reality, the true success of an implant is seen in the prosthetic phase, when the function, aesthetics, occlusion, and patient satisfaction finally come together. Then we are able to achieve a very good prosthetic to the patient. Today, in the next 15 to 20 minutes, we will briefly discuss about the components involved, impression techniques, abutment selections, and prosthetic workflow. So, starting with the first slide, dental implant prosthetics aim to restore function, aesthetics, and long-term health to the patient. So mainly the prosthetics procedure include three stages: the pre-prosthetic stage, impression stage, and the restorative stage. The pre-prosthetic stage includes either a single stage or a two-stage surgical protocol. So after the surgery is complete, after successful implant placement, at the time of putting the cover screw, we have to decide if I'm going to put the cover screw or the healing abutment. If I'm going to put the cover screw at the time of implant placement, that will be a two-stage surgical protocol. And if I'm going to put a healing abutment immediately after placement of the fixture, that will be a single-stage implant surgical protocol. So what are the key factors which decide whether I should go for a single stage or a two-stage surgical protocol? If the implant is quite stable, if I was able to achieve a torque of 35 NCM at the time of implant placement, then it is better to put a healing abutment over it immediately after the fixture than to go with the cover screw. Otherwise, I have to cut open the gum after 3 months and put a healing abutment over it, which makes the patient little bit uncomfortable. If I have done any sort of bone grafting procedure or sinus lift procedure or any procedure by which I was not able to achieve that good primary stability, in those cases, I should hide the implant completely inside the soft tissue by putting a cover screw over it and achieving a primary closure. So what is the role of putting a healing abutment? It helps in forming a gingival contour around the fixture so that I can snugly fit my prosthesis over it. Now, how a healing abutment is placed over the fixture? With the help of hex driver, we are simply going to hold the healing abutment with the hex driver, and I am going to simply screw it over the fixture with my hand. So it should not be ratchet tightened, it should be hand tightened only. Now, how to choose a healing abutment? It has to be chosen according to the cervical diameter of the tooth to be replaced. If I'm going to place an implant in the anterior region, obviously I'm going to choose a narrow diameter healing abutment. And if I'm going to place an implant in the posterior area, in those cases I'm going to choose a broader diameter healing abutment. So 4 is mainly used in the anterior areas, 4.5 in the canine or premolar areas, 5.5 again maybe some cases premolar areas. Sometimes if I'm going to put it in the 6 region, in those cases where the 7 is mesially drifted and there is less amount of occlusal space for the placement of a crown in the 6th region, in those cases I can put a 5.5 mm healing abutment in the 6th region also. Other than that, 6.5, 7.5, 8.5, 9.5 are also the diameters for molar areas. The wider diameters are mainly used in immediate implant cases to cover maximum amount of socket surface. We should always confirm the complete seating of the healing abutment by taking an X-ray. Once, sometimes we feel like we get a false tightening. We feel like my abutment is completely tightened, but when we take the X-ray, it is rubbing against the bone, and it is not gone completely inside the fixture. So we should always confirm the seating by taking an X-ray. If this is the case, we need to remove some part of bone, and then we need to fix the healing abutment. Coming to the impression stage, impression has to be taken with the help of impression copings, which are of two types, open tray and closed tray. Also, open tray is called as pickup impression coping or pickup impression technique. And using closed tray, we do the transfer impression technique or transfer impression coping. These are the open tray impression copings are slightly longer and irregular. They are sharp, and the closed tray impression copings are round and small. All the copings are of two types, hex and non-hex, in which the hex has to be used in single implant cases, whereas the non-hex has to be used in multiple implant cases when the implants have to be connected together. The choice of impression coping should be according to the choice of healing abutment. So if I have chosen a narrow diameter, a 4.5 diameter of healing abutment, the impression coping chosen should also be in match with the healing abutment. That should be of 4.5. So if I have chosen a 6.5 diameter impression healing abutment, I will choose a 6.5 diameter impression coping. This is the non-hex impression coping. And this is the hex variant, in which the hex of impression coping will directly fit into the internal hex of the fixture. There are two types of impression techniques that we generally use. That is, as I mentioned, open tray and closed tray. So this is the closed tray impression coping, hex variant, in which the screw and coping are separate, whereas in the non-hex closed tray impression coping is single piece. The screw is attached with the coping. So for the placement of coping inside the patient's mouth, first we need to put the coping, fit the hex of the coping with the hex of the fixture, and then we are going to put the screw from the top and tighten it with the help of hex driver. Once it is completely seated, then we are going to start making the impression. To make the impression, we are going to first put the light body surrounding the impression coping and all over the arch, and then we are going to put the heavy body on the impression tray, and we are going to position it. Once the material is set, then we are going to gently remove it. After removing the impression, we are going to remove the impression coping from the patient's mouth, and we are going to put the healing abutment back, and we'll send the patient off. In the impression, we are going to you take the impression coping with which we took the impression, and we are going to fit the analog with that impression coping. And this is the analog. So we'll fix the analog with the impression coping, and we are going to tighten the screw from the back. Once the screw is tightened, then we are going to seat this entire thing, the impression coping with the analog, matching with the indentation. There is a flat surface on one side of the impression coping. So this flat surface indentation will be seen on the impression. So we are going to match this indentation, and we are going to insert it in the same manner. Once it is inserted, our procedure is complete. We are going to send it to the lab. They are going to pour it and we are going to fabricate a crown over it. This is the open tray impression coping. This is slightly long with a longer screw. Once it is seated inside the fixture, we are going to prepare the tray for it. So as it is also called as a pickup impression coping, so it has to be picked up inside in the impression. So we have to prepare the tray for it. We have to create a hole in the tray for smooth movement of the tray. We have to check whether my tray is moving smoothly or not. Then we are going to start making the impression. Going to put the light body, and then we are going to put the heavy body over it. We are going to remove the excess material from the top surface of the screw hole. Once the material is set, we will access the screw hole through the impression tray, and we are going to remove the screw. Once the screw is removed, then we are going to remove the impression tray. After removing the impression tray, we will see that the impression coping is picked up inside the impression. Now we are going to place the analog over it. If it is a hex impression coping, we are going to fit the hex of the coping with the internal hex of the analog, and we are going to tighten the screw from the back side. After this, the impression is sent to the lab for the lab process. We can also get the gingival mask made. It can be done by us, or it can be done by the lab person also. So the main motive that is that lab analogs 1 to 2 mm of surface should be covered with the gingival mask so that we can see the connection clearly. So this impression type is a closed tray impression technique. As we can see that the complete indentation of the impression coping is being captured in the impression. This is the indentation of that flat surface which is there in the impression coping. This is the open tray technique. In this, the impression copings are picked up inside the impression. And this is the lab analog, which is the replica of an implant in the model, which is used for the fabrication of prosthesis. So these are the pickup impression copings. These ones are the transfer or closed tray impression copings. We should always ensure the complete seating of impression copings also after taking an X-ray. If it is completely seated, then only we should go ahead with the impression. Otherwise, it can lead to a false placement of the impression coping or false marking of the position also, which will lead to finally when we are going to put the crown is not going to seat properly. Then jig trial. Jig trial can be done in full arch cases also, or if we have any doubt if my implant is at slight angle or not, if I have any sort of doubt in the formulation of the prosthesis, then also I can get a jig trial done. Coming to the restorative stage, the restorative stages are of two types: cement retained and screw retained. What is a cement retained crown? It consists of three major parts. It will have an abutment, screw, and a crown. So what is the procedure? Once I'm going to seat the abutment, I'm going to give a complete torque to the abutment. Then I'm going to put Teflon. After giving complete torque, I'm going to seal the screw head with the Teflon. I'm going to put cement on the undersurface of the crown, and then I'm going to cement it. So for the fabrication of a cement retained prosthesis, there are three types of abutments. Either we can make a cement retained with a dual abutment, milling abutment, or an angled abutment. What is a dual abutment? A dual abutment is a regular stock abutment which is available in different diameters and different gingival height. The diameters available are 4.5, 5.5 and 6.5. The gingival height available are 1 to 5.5, which can be chosen according to the gingival height of the patient. So as I mentioned in the previous webinar, that with the help of a broad end of the depth gauge, we can seat that conical part of that broad end of the depth gauge over the fixture, and at whichever line the gum is going to lie, that will decide the gingival height of my patient. So we can choose the diameter according to the cervical diameter of the tooth to be replaced, and the gingival height can be chosen according to the gingival height of the patient. So if it is an anterior, I'm going to choose the 4.5 diameter dual abutment. In premolars, we'll choose 5.5, and in molars, I'm going to choose the 6.5. If it is a single arch case, we will choose single implant case, we will choose hex, and if there are multiple implants connected together, I'm going to choose non-hex abutment. Next comes the dual abutment. As the total height of a dual abutment is only 5.5, and there is a black color line on it which indicates that it should not be cut beyond this level, which means that the height of the abutment should be minimum 4 mm to go for a cement retained prosthesis. If it is cut beyond that, the abutment will not be big enough for the crown to retain. So that is why in those cases, if there is very less of interocclusal space, we should go for a screw retained prosthesis rather than a cement retained one. Next comes the milling abutment. As I told you that the total height of dual regular stock abutment is only 5.5, and if I have placed an implant deep inside the bone and I feel like this height is not sufficient enough to make a prosthesis over it, so in those cases, I can use a milling abutment. It is long. It has a 12 mm of total height available in different gingival height and again different diameters. As its name says, it is a milling abutment, so it can be milled according to different shape, different contour, and as the height is different, it allows the doctor to place an implant on the deeper side. Next comes the angled abutment. Over the angled abutment also we can put a cement retained prosthesis. So if I have placed an implant at an angle and I want it to look straight in the oral cavity, I'm going to take the help of angled abutments. They are available in two angles of 15 and 25 degree and different gingival height. Basically, it is used for angle correction. 15 degree is mainly used in the anterior region. To give a screw retained prosthesis, there are again three options: the metal casting abutment, screw abutment or a multi-unit abutment, and a temporary abutment. For the metal casting abutments, we have one diameter of 4.5. The gingival height is standard 1 mm. If I want to go ahead with the prosthesis using metal casting abutment, then I have to choose, if it is a single implant case, I have to choose hex, multiple implant case, non-hex. So it is standard, it has only one diameter of 4.5. As its name says, it is a metal casting abutment, so it can be casted to any diameter, any gingival height and any angle also. So there are not much of options in this, everything can be casted. So we have to choose only hex and non-hex. This is the temporary abutment. Temporary abutments are used for the fabrication of temporary prosthesis. This is the titanium temporary abutment and this one is the plastic one. The plastic temporary abutments comes in three diameters of 4.5, 5.5 and 6.5, but the gingival height is standard, that is only 2 mm of plastic. The gingival height is standard, that is only 2 mm of plastic. The plastic temporary abutment comes in three diameters of 4.5, 5.5 and 6.5, but the gingival height is standard, that is only 2 mm of plastic. The gingival height is standard, that is only 2 mm of plastic. The Basically, the temporary abutments are only and only used for temporary prosthesis. This is the screw abutment or a multi-unit abutment. So this is a straight screw abutment, straight multi-unit abutment, which comes up with a delivery holder. It is used to pick the multi-unit and it is used to screw it in the patient's mouth. It is also available in different diameters and gingival height, which has to be chosen according to the patient. If I want to choose, if I have angulated the implants and I want to choose an angled, I want to place an angled screw abutment over it, there are two options, either 15-degree or 30-degree. It also comes up with a delivery holder which has a slot on one side, which allows the screw to go easily and to get tightened. So this is a small demonstration of a straight and angulated screw abutment. How is it placed in the patient's mouth? So it comes up with this type of delivery holder. We are going to screw it with our hand, then we are going to remove this delivery holder. For final tightening, we have to use the adapter which comes in the prosthetic kit. We have to seat this adapter, put a ratchet over it, and then we have to give a torque of 35 Nm. Now, angulated multi-unit abutments. This one is the angled multi-unit abutment. It is also placed with the help of delivery holder. Once the angled multi-unit is placed, then we are going to tighten it with the help of Hicks driver. The screw in this angled multi-unit abutment is same which is there in the all the abutments like dual abutment, milling abutment, metal casting abutment. In the angled one, the screw is same. Once it is tightened with the hand, then we are going to give a torque of 35 Nm with the help of ratchet. Once the torque is given, then it is good for the final prosthesis. If suppose I feel like my plastic delivery holder is loose and it is not holding the multi-units properly, in those cases there is a titanium delivery holder available. I can screw that titanium delivery holder over this angled multi-unit, and then I can tighten the screw nicely. So this is the titanium delivery holder. After the angled multi-unit is tightened, we are going to remove the titanium delivery holder. These are the comfort cap. As after putting fixture, we put healing abutments. So after putting the multi-units, we put comfort cap over it just to give a contour to the surrounding gums. This is the multi-unit level analog. If we are going to use multi-units for the fabrication of prosthesis, we are going to use these type of analogs for the lab process. This is for the temporary prosthesis. If I am going to give a temporary full arch prosthesis to the patient, then I am going to use these temporary cylinders, either Hicks or non-Hicks according to my case. These can be chosen, these can be ordered, and the company is going to provide you, and you can use it in your patient. This one is now for the permanent prosthesis, there are two options. Either we can use the metal cylinders or I can use the burnout cylinders. In the burnout cylinder, they are completely made up of plastic, as its name says, burnout. They are completely going to go in the in the lab process. This is the metal cylinder. In this, the connection with the multi-unit will always be with the metal. So it will provide a very, very pure connection. Pure means from the company. So it is a company-based connection here. So we can choose if I want to use a hex or a non-hex. These are the polishing protectors, which usually are used to tighten, to cover the inner surface of the metal cylinders. So when they are going to go in the lab process, the inner surface of the metal cylinder becomes rough because of the wear and tear in the lab process. So when we fit it over the multi-unit, the fitment is compromised. So to protect the inner surface of the metal cylinders, we put these polishing protectors so that the inner surface is protected. If we want to make an impression over the multi-units, we have these type of impression coping. This one is the pickup impression coping over the multi-unit, and this is the transfer impression coping over the multi-unit. Pickup and transfer, if in some cases because of overuse or because of the distortion or screws are lost, so the screws can be purchased separately. So these are the open tray and closed tray impression coping. So the full arch prosthesis can be fabricated using all these type of abutments that I showed you till now. If we want to go ahead with the digital procedure, then we have to use the comfort cap, which are made up of either metal or PEEK. So these both can be scanned. So basically, the comfort caps, the scan comfort caps are available in two materials right now, titanium and PEEK. We can use any one and we can scan over it, send the data to the lab, and we can go ahead with the prosthesis. This is the titanium cylinders which are used over the multi-unit for the final fabrication of prosthesis. This is the digital analog. Like for the manual process, we have regular analogs. For the digital process, we have digital analogs. It looks exactly the same, but the code is different. It has a matching library, digital library to it, with which we can plan the fabrication of the prosthesis. So as these cylinders are are placed over it, it is placed with an external connection, and the screw is also very small, so it should not be over torqued. So the maximum torque that can be given over the screw is 25 NCM. The adapter, which in video I showed you one adapter which is used for the final tightening of the multi-units. So this is that adapter which is there in the prosthetic kit, which can be purchased separately. We can also make the impression at the abutment level over the dual abutment level by using this pickup impression, by using this type of impression coping. This is a snap-on impression coping, which is just simply snapped on over the dual abutment, and this type of analog will be used if I'm going to use this type of impression coping. So this is an abutment level impression coping. Another type of abutment level impression copings are these two, as I'm going to make an impression over the screw abutment. So these two are also abutment level impression copings. These are the fixture level impression copings. If I'm going with the if I'm going to choose the abutments fixture level, if I'm going to go with the process fixture level, then I'm going to use these two abutments. If I'm impression copings, if I'm going to go ahead with the abutment level impression, then I'm going to use these impression coping according to the choice of the abutment. Coming to the fixture level digital components. So if I'm going to place if I want to go ahead with the digital process at the fixture level, first I need to put a scan healing abutment. So this is a scan abutment which is used, which is screwed over the fixture and which is scanned. The scan data is sent to the lab along with this custom abutment, which is used to customize any type of crown and which is used for the fabrication of final prosthesis. If I want more customization and I'm not happy with the diameters or with the gingival heights available here, I want to customize it more, then I can use titanium blanks. These are pure titanium blocks which are used for the fabrication of an abutment according to the patient. So by these blanks, abutment can be fabricated over which I can put a crown. This is the digital analog which is used over the which is used in, if I'm going with the multi-unit abutment procedure, this is the fixture level digital analog. So, if I'm going to place a cover screw or a healing abutment, the final torque that I'm going to give is 5 to 10 NCM. If I'm going to use any type of abutment among these, then I'm going to give a torque of approx 35 NCM. If I'm going to put over the multi-unit, I'm going to use the cylinders. As the cylinders are tightened with a very, very small screw, I should not over torque it. So the maximum torque should be 25 NCM. The temporary abutment should be given a maximum torque of 25 NCM. Now, after the complete placement of the crown, just to complete the procedure, what all clinical tips you should take care of in your practice whenever you are going to give your prosthesis to the patient. First is always verify a passive fit. Now, how will you do that? You have to ensure that the prosthesis is fitting passively without causing stress, which helps in preventing the screw loosening and screw fracture also. So if you are giving a conjoint prosthesis, then suppose two crowns, 6 and 7, your 6 and 7 implant you placed, and then you are giving a conjoint crown, then you should be very, very sure that in both the fixtures your abutments are seating passively. Otherwise, if one screw is active, the entire load will be on that prosthesis only, which will lead to either screw loosening or screw fracture at a later stage. We should always ensure to make the impressions nicely. If we have taken precise impressions, then our prosthesis will be well fitted and it will long last. Yes. Next is we should always respect the soft tissue biology. Proper soft tissue management helps in improving the aesthetics of the patient. So we should always make sure that our soft tissue is nicely contoured. We should always control the occlusion. So the whatever occlusion we are achieving, it should be balanced. There should all the excessive forces should be managed properly, and all the mechanical complications should be managed nicely. Prefer retrievable restorations whenever possible, which means we should always go with a screw retained or SCRPs, screw cement retained type of prosthesis, because if it is non-retrievable, if we have given a pure cement retained type of prosthesis, it is very, very difficult. If patient is coming to us after 1 year, 2 year, complaining of screw loosening, then we have to remove the entire crown by cutting only. There is no other option. Maintain regular follow-up. So routine checkups and giving proper instructions to the patient about maintenance of good oral hygiene is very, very important. So that's all about today's session. Thank you everyone for your patience listening. I hope this short webinar was informative and useful. Thank you.